Today's speaker is very special. It's Ann Borgmeyer. She's been a pediatric nurse practitioner since 1977. For the past 20 years, she has worked at St. Louis Children's Hospital in the inpatient setting, caring for children with respiratory conditions. She is certified as an asthma educator, and she recently completed work on her DNP at the University of Missouri St. Louis. Let's welcome Ann.
Thanks for the introduction. So I'm always excited to talk about respiratory things. It's been my passion for really more than 20 years now. Most of the time at St. Louis Children's Hospital, I manage the care of kids with asthma who are admitted to the hospital. But during bronchiolitis season, I kind of switch hats and work with the kids with bronchiolitis. And so I've been kind of championing our protocol or our guideline at the hospital for many years now, to do the best we can with the evidence that we have to take care of children and their families. So I was kind of excited when there was a new guideline to talk about, just to see if we'd been keeping up with the evidence year after year. I really don't have anything financial to disclose. Our objectives are going to be pretty simple. We're going to define bronchiolitis. We're going to describe the epidemiology of bronchiolitis. And we're going to discuss the current evidence and guidelines for the management of bronchiolitis. So what is bronchiolitis? You would think that would be simple, right? But I kind of get frustrated with this all the time because I will hear that I've got an admission coming and it's a 5-year-old with bronchiolitis. Or I hear that, there is a 7-year-old coming in with influenza and bronchiolitis. No, they really aren't. They're not coming in with bronchiolitis. They may have a viral infection, but they do not have bronchiolitis because really we're talking about children less than 2 years of age when we talk about bronchiolitis. And in some of the studies that are done, they're talking about kids that are less than 1 year of age. So the definition by the guideline that we're going to talk about from the American Academy of Pediatrics, it's for children 1 to 23 months of age who are having a viral respiratory illness. When we talk about pathophysiology, we're talking about, I was going to show you lots of slides. I had some pictures in here of slides of all kinds of sloughing epithelial cells and things like that. I decided we didn't need to look at it. But we know it's a disease of small airways. It's acute inflammation. It's edema, and it's necrosis of epithelial cells. It sounds like it would be like asthma, but they're really two different animals. Signs and symptoms, if I asked you all to call out the signs and symptoms, we'd have a list in no time. We've all seen it. We know what it looks like. Starting out with that runny nose and developing into a cough, tachypnea, wheezing, rales, using accessory muscles, and or nasal flaring. Now at this point, a little thing was supposed to pop up that said that there was fever, but it's not going to pop up for you, but you all know it's there. It may follow a little different course with different viruses, but most of the time you can expect fever with these viruses. One thing to take a look at, and I don't know how well you can see it, is in the blue box. The guidelines specifically speak to the fact that they're not writing these guidelines for kids who have recurrent wheezing, for kids who have immunodeficiency, who've had a transplant, who have underlying respiratory conditions, neuromuscular disease, or congenital heart disease. Now, it's not to say that the guideline information might not be of benefit to those kids, but those are kind of outliers of the child that we're talking about with bronchiolitis. The care that we give them may involve all of these same things, but they're not included in the data or the studies or the evidence that kind of built the guidelines. What about virus? So, if I went back to when I first started practicing, and we thought, sure, kids had viruses, and we never, ever knew what virus they had. We treated them by what they did. We took a look at them, and we decided our care to support them, and we never knew what it was. And then we started to be able to capture some viruses, and now with multiplex testing, we get more viruses than anybody ever knew that there were strains for. So we know a lot more about the viral makeup of these kids with bronchiolitis. When we look, and I think it's, hold on, I'll tell you. It's Miller, Gebetstrubik, and Carroll, and all. They did a great kind of review in 2011 of the past 4 years of viruses in kids who presented with viral illness. And they kind of came up with these numbers to give us some idea of what the predominant viruses are. And when you look, I don't think it's a no-brainer that RSV is going to be up at the top of the pack, with 76% of the kids in their cohort that had RSV. 90% of kids in their first year of life are going to get RSV. 40% of those kids are going to have lower respiratory symptoms that are going to be very obvious when they have RSV. And then the really sad part to tell parents, I love it. It's usually a dad that says to me, well, I'm so glad we got this and got it over with so we don't ever have to go through this again. And then the bad news is that there is no long-term immunity. And so, yes, they can get it again. Usually not the same strain in the same season, but it's not even that for sure. But they can have RSV again, no long-term immunity. Rhinovirus, which we couldn't capture very easily until recently, was found in 39% of the subjects in the cohort. However, keep in mind that when you swab for RSV, you may be seeing current or previous virus. You're not always positive that rhinovirus. You're not sure that rhinovirus is really the contributing factor to the current illness. So when it shows up that a kid has RSV and rhinovirus, you can be certain that the RSV is there. The rhinovirus may or may not be comorbid at that time. Might have been something they had previous. But that's why the numbers don't add up. There are 33% of the kids in the studies that had more than one virus. So that's why we've got 76 with RSV, 39 with rhino, 10 with influenza, 3 with human metapneumo, 2 with corona, 1 with paraflu, and some with adeno, because there were more than one virus. Now, I looked for this, and I couldn't find anything that said that more than one virus made you have worse outcome. But in my gut, when I see a kid who's in the hospital and they've got 3 viruses identified, those are kids that usually ended up with a lot of intervention. And in the end of the talk, when we talk about where could we study more, it might be a thing to look at. But, sometimes the child that comes in and really does have 3 concurrent viruses ends up very sick. Now, if you look at the box on the right, that's the CDC kind of seasonality of RSV. And it's the data from July of 2013 to June of 2014. And you have to feel sorry for, who's from Florida? Yeah, I'm sorry for you, because when you look at Florida, their seasonality goes all the way from July to February before they get a break from RSV. The rest of us are kind of in those winter months. If you look at kind of down midway, Region 5 and Region 7, because I'm in St. Louis, so we're kind of in the overlap there between Chicago and Kansas City, and you'll see that we usually start up sometime right before December, and then we usually end up sometime mid-April, and that's what it tells us. So I looked at the hospital to see what our data shows. That's probably just a bunch of lines to you, but what it tells you is over the last 5 years, that's kind of what happened. Sometimes we had a little slower start up and a little slower wind down, but in general, we were in that December-ish to April-ish time, even though some years we start up fast and some years we start up slow. And if you look, the blue one, the light blue one that stops, that's because I sent my slides in the 1st of February. So that's where we were this year, and we started a little slower, but we ended up, we climbed up to meet the peak of the 2011-12 year. And I think we're probably, from what it looks like, we're going to come down right mid-April like we usually do. As far as hospitalization, if you talk about asthma, it's the #1 admitter for kids in most children's hospitals. It's for sure the number in the top 3 of most children's hospitals. But if you talk about bronchiolitis, it's the #1 cause for kids less than 12 months of age. So there's a lot of kids, 100 to 126,000 admissions per year in the US, and it is a big cost. $1.73 billion are spent on bronchiolitis. RSV admits, if you look at just RSV alone, 5.2 per 1,000 children less than 24 months. But if you want to see where all the money really is, take a look at the last line, because kids between 30 and 60 days, their numbers are 25.9 per 1,000. So where does it hit hardest? In those little ones, age 2 to 3 months. Now, for the guidelines, the first guideline came out in 2006, and we haven't had another guideline until now, 2014. So it's been a long time in between. And like I said, you've probably done the same thing we've done. You've kind of paid attention to the evidence coming out and tweaked your practice along the way to kind of keep up with what's going on. So these guidelines give us an opportunity to say, have we done a really good job? Are we keeping up? Is our practice current with what the guidelines say we should be doing? One thing, and I'm really sorry that you can't see this because I think this is kind of important. And I might have to turn around and look at it. Oh, it's really hard to see. When you look at any guideline, it's important to know why are there strong recommendations. Even some of my colleagues say, if you can make any sense out of this strong recommendation and evidence thing, you'd really help me out. Because you end up with strong recommendations, but why? So it's based on how good the evidence is, and then benefit versus harm. So when you go to the top of the list, you've got clinical trials right on topic, right with the right population, that show clear benefit or harm, and you come up with a strong recommendation. And as you go down the line, the evidence gets weaker until we get to expert opinion or nothing, because in evidence X at the bottom, for some reason we can't even study it, and we're going to run into an evidence X in bronchiolitis because we can't withhold fluids from kids with bronchiolitis to see if they really need them. So the evidence X is going to be we really don't have a study on that. But if we go to the recommendations, they are mixing and matching benefit versus harm. And then sometimes we have a weak recommendation where it seems like we've got maybe just one good study, but boy, it was strong. We don't have a lot. It wasn't big, but it seems to make sense. Well, we're even going to get a recommendation out of that. It might be a weak recommendation, but we might get a recommendation because it looks like there's an advantage to the child and family. This slide, a little bit easier to read maybe, says what are the implications? So this is the implication. If it's a strong recommendation, you should follow the strong recommendation, right? Good evidence and a good benefit. So yeah, that's kind of, we're going to like stick to our guns and we're going to follow that recommendation. But as you go down the line, you get a little bit more mixing and matching because maybe it's not strong, it's moderate. You still would be prudent to follow that. Or maybe it's weak. Okay, well now I can think a little bit more about my family to see would this really be good for them. And when you get down to the bottom, you really can consider the family a lot because we don't have good guidance. So that's the idea behind this. But when you have a strong recommendation, it seems like that's probably one we should follow. Now, as far as treatment, it's really hard. I love to be interactive, and this is really tough. But what I really want to do, and it's not a big deal, and don't be afraid there's no wrong answer. But every once in a while, I'm going to ask you if it's something, and I just am trying to get a pulse on practice. And I don't care what setting you're in. If you're in primary care, if you're in urgent or emergent care, or if you're in the inpatient setting. I'm going to ask you a couple questions along the way. Is it something you do kind of all the time? Is it something you do some of the time? Or is this something you never do? Just so we can kind of see what practice is like. Because, I think we all practice in a vacuum, and part of the point of coming here is just to see what's going on other places. So there won't be any right or wrong answer, and don't worry if the guidelines say you're wrong. It doesn't matter. I just want to see what the practice is. When we start talking about treatment, and I might as well tell you there's 14 key action statements. We won't belabor some of them at all, and we'll talk about some of them more in depth. And when you get to a key action statement, sometimes it's standalone, and sometimes there's like 3 parts to it. So in the first key action statement, it's about diagnosis. So before we even look at these, I'd like to know who routinely, let's say more than 75% of the time, swabs a child who comes to you with bronchiolitis. Raise your hand if more than 75% of the time. Okay, who about 50% of the time swabs? Who never swabs? All right, that was interesting. So for those of you who couldn't see, it was the never swabs that got that vote, really. So what the guidelines tell us is to diagnose bronchiolitis and assess disease severity based on history and physical exam. So that's what you're telling me you're doing. You're looking at the kid, you're looking at the constellation of symptoms, you're looking at their course, and you're diagnosing bronchiolitis. And that's exactly what the guidelines are saying. That is evidence quality B, and the recommendation is strong. The other thing that they talk about is they talk about that key point, is they talk about the importance of getting a good look at the kid. So by nasal suctioning, repositioning, to make sure that you're not looking at the child who's just got a whole nose full of junk, who can't breathe and now starts to breathe hard, clear them out, give them their best advantage, and then see what they look like. 1B says, assess risk factors for severe disease when making decisions about evaluation and management. I think that makes sense. If you know that you're looking at a child who's going to maybe decompensate quicker than another child, you've got to keep that in the back of your mind, right? You might not want to send that child home if they've got some risk factor that says they're going to be more sick. And if you look at risk factors, they talk about congenital heart disease and chronic lung disease like BPD, congenital anomalies. And then one I always forget about is in utero smoke exposure. Those kids have proven to do more, to have a worse course than kids who have not had in utero smoke exposure. Immunocompromised children and kids with genetic anomalies. The other thing is risk of apnea. So what is the risk of apnea? It's kids less than 1 month of age. It's also less than 48 weeks post-conceptual age for preterm. And then anybody that's had an apneic event. So if the mom's telling you they were fine, they cough, then they turned blue and they seemed like they didn't breathe for 5 minutes, and I called 911, and then 911 came and said, okay, that all raises your suspicion that this child's not going down a very good course. So that's going to change maybe your evaluation and management. And then way up at the top of that slide, it says the ability of the family to care for the child. So I recently had a mom who had triplets at home, twins at home, and was in with her 2-month-old. And they were all sick. All the kids were sick. And, that really affected that mother's ability to take care of the child, even with help at home. So that might make you make a little different decision in management for that child. A big different decision. Here's our question about to swab or not to swab. So the radiographic or laboratory studies should not be obtained routinely. This evidence quality is B. This recommendation strength is moderate. And what they end up telling us is that if we swab, we probably really won't do anything different than if we don't swab. If we know it's a specific virus, so we know it's human metapneumovirus, how does that change our treatment? But they say in the guidelines, consider the swab if you're going to cohort. We do not have the luxury at our hospital to have all private rooms in bronchiolitis season. So we swab for the purpose of cohorting. And then if you're going to, the other reason, confirm RSV in a kid who's getting Synagis. Because what's the guideline going to tell us? If they've got RSV and they're getting Synagis, what happens? We stop Synagis. No more doses that season. So it's a big cost, and it's a big cost savings. They don't need it that season. The guidelines tell us it's a reason to swab. Radiology, it says chest x-rays result in antibiotics that did not affect the course of the illness. Consider a chest x-ray. So when would you? You all probably, you do it. There's times you consider it. I'm sure it's when you've got a severely ill child that looks like they're heading to the PICU or intubation yes, we're in kitchen sink protocol then. We need to know what's going on and make sure we're not missing something else. The other thing is, and if you suspect an airway complication like pneumothorax, or what about the child that's day 5, looking great? Day 4, they looked pretty good. Day 5, they look great. Day 6, they start to run a fever. Day 7, they look like dirt. You're going to chest x-ray that kid probably. He's got a high fever now. Didn't have a high fever before. You're going to do a chest x-ray just to see if we've got something on top of that initial virus. Do we have, now at this time, a pneumonia that we need to pay attention to? A lobar pneumonia, not a schmutzy viral-looking picture, but something consolidated. All right, before we even look, who gives albuterol 75% of the time or more? Who gives it about 50% of the time? Who doesn't give albuterol? Okay, we're tied on that one all the way across the board. Some of you said yes, some of you said sometimes, and some of you said never. So this is a strong recommendation. It's evidence B. And it says clinicians should not administer albuterol. That's tough, isn't it? Because why do you do it? I know why you do it. I know why I want to do it. You want to do something, right? And we don't know who responders are. We do not have a way right now to know who's really going to respond. I'd like to tell you that we think they're going to respond if they've got a strong family history of asthma. That science may be coming. It's really not there yet. We don't know that, really. So it says in Gadomski and Scribani, Cochrane Review, 30 studies, 2,000 infants, 12 countries, indicated no benefit in the clinical course using albuterol. And then the conclusion, the potential adverse effects, tachycardia and tremors, and the cost of these agents outweigh any potential benefits. So remember what we said in the very beginning about these strong recommendations? That we were advised to kind of try to stick to them like glue? This is kind of a hard one. There may be a small subset, but we really don't know. If albuterol is tried, what the guidelines say is take time to carefully identify response. So the guidelines talk about when you start albuterol, so let's say you send the family home with an inhaler and an aero chamber, and then they continue, you don't even assess them. They pick it up at the pharmacy, they're giving it at home, and nobody even assesses it, and 6 months later, the family's still using albuterol, and we don't even know if it helped that child at all when they had the bronchiolitis. That's not where we want to go with this. Most studies, and also to know most studies excluded the intensive care because it certainly falls in kitchen sink protocol for the kid in the intensive care unit. That it is probably when you're trying anything and everything on a kid who's decompensating, it's worth trying. So those intensive care kids were out of these studies. I want to just show you something, and I'm going to have to go close to read it. I want to say it's Cincinnati. It's Ralston, and I want to give them credit because it's copyrighted. Yes, I can read it. It's Cincinnati for sure. And it's where Ralston, who really was the leader on the guidelines, practices. And they, along with 4 other centers, did a study that they've done a poster on at the American Academy meeting, and I think a publication is in print, where they found out that if they used a scoring system, they ended up actually using albuterol more appropriately. Kids who benefited from it got it, and kids who didn't benefit from it, they stopped it. They found it crucial to using albuterol. They use a score called the WARM score, and it's for wheezing, air exchange, respiratory rate, and muscle use. They use the same score with an E on the end of it. They call it a WARM-E score for asthma, and then they include prolonged expiration. So what it really is, it's just a scoring system looking at those components. If the child gets a 3 on the score, they trial albuterol. If they trial albuterol, they do the score after the albuterol. If it's improving, they continue. If it doesn't show difference, they stop it. And so in this study, it really did I don't think it affected length of stay. But it did decrease the use of albuterol over previous years in those institutions. We kind of mimicked it at our institution this year. We have a score we call the CHAS score. It's the Children's Hospital Asthma Score. But really, when we looked at it, it was warmy. And so we decided, because we read this and it decreased their albuterol use, we used our CHAS score just to pre-post, if we were going to trial anybody on albuterol, someone who wasn't doing well, so that we could get a pre-post score. And if they were changed by the albuterol, we were advised to continue. If they were not changed, we're advising to stop. And at the end of the season, we're going to pull the data on this to see how our score held up. We used our score rather than this score because it was already embedded in our electronic record. And it was so similar. But and so I can't tell you the results of ours, but I do know that they're about ready to publish theirs. And this is just, I put in my slides, it's the poster that talks more about their study at the 5 sites. So who uses racemic epi? A lot, 75% or more of the time. Who uses it 50% of the time? Who uses it rarely? Okay, so that's kind of where I thought we would be with racemic epi. If you look at the guidelines, they say clinicians should not administer. It's strong, the evidence is B. And what it says is that we know it's used with dexamethasone and croup, right? They're talking here about using it independently, so that's one thing to keep in mind. But in 2011, there was a systematic review by Hartling with some evidence to indicate reduced admission in the first 24 hours outpatient compared with placebo, and they found no evidence for inpatient use. But it's such, we just don't have enough evidence on it right now to know where we're going with it. So the racemic epi, it's in our bucket of what to try when we have kids that aren't doing well, along with albuterol. So it's just another option for us. It's something that's easily doable. We're used to doing it. And so we do keep it in mind. But really the strong recommendation here is not to use it. Hypertonic saline? Anybody? Yes? There's people using it. So nebulized hypertonic saline, it says, should not be administered to infants with a diagnosis of bronchiolitis in the emergency department. It was moderate. It was evidence B. In the emergency room, we have not many studies, but it wasn't shown to help. However, it says the clinicians may administer nebulized hypertonic saline to infants and children hospitalized for bronchiolitis, so kids in the inpatient setting. However, it's weak. The recommendation's weak. We don't have a lot of evidence on it. It was based on length of stay, and I want to tell you it was something like a minimal amount of length of stay that was inconsequential. So if it works, we're not sure yet. Was it harmful? It wasn't. And they decided that it was the 3% that was safe, and it's never been studied in the intensive care unit. Okay, here's a better question probably. How many people give steroids for bronchiolitis 75% of the time or more? Nobody. 50% of the time. Some. Rarely. Some. Okay. So the strong recommendation here, based on evidence A, this is the strongest you're going to see in here. It's good quality evidence with the right population and good clinical trial studies. And the strong recommendation says clinicians should not administer systemic corticosteroids to infants with a diagnosis of bronchiolitis in any setting. So if you want to hang your hat on one thing that's strong in these guidelines, this would be it. Corticosteroids alone do not provide significant benefit to children with bronchiolitis. The evidence for a potential benefit of combined corticosteroid and agents with both alpha and beta agonist activity is at best tentative, and additional large trials are needed to clarify whether this therapy is effective. There is no evidence of short-term adverse effects from corticosteroid therapy other than prolonged viral shedding, but inadequate evidence there's still inadequate evidence to be certain of safety. I find this one interesting. It's not strong, though. It's all weak, and the evidence is not good. So we definitely need to look at it more. But in previous guidelines, it had us keeping kids with bronchiolitis with saturations in the mid-90s. So we treated it different. Asthma's always been 90, but for bronchiolitis, there was some thought that the kids are littler and they needed to have higher levels of oxygen. And so supplemental oxygen to keep them mid-90s was the way that the previous guidelines were written. We don't have a lot of good evidence, but now there's a thought that maybe we don't need to do that. Because, and they're basing it, I put the little mountain picture down there, because they're really extrapolating evidence on kids that were done in high altitude and found that when they desatted, it wasn't harmful. And so we don't think there's the harm there that we once thought for letting kids' sats drop into the 80s. So we think transient desaturations are not harmful. That they found real lack of accuracy of pulse oximetry in the 76 to 90% range. So if you're going to hang your hat on giving oxygen to kids on equipment that isn't even all that reliable, it may not be necessary. They also found it prolonged hospitalization in kids that otherwise looked good. They looked good, but they were dipping to 89. So we put them on a half a liter and keep them another 3 days. The whole time they're eating, they get playful, they look fine, and they're desatting a little bit. And now the guidelines are saying we're not so sure that's the right thing to do. We might not need to do that. So this is going to be some evidence that you get to kind of take into consideration what's going on with your patient, because it's weak. But you can think about it. You've got some support in not giving oxygen and not continuous pulse ox on those kids. Yes? Right. He says when people work in high altitude, it seems appropriate, but people at sea level, it doesn't seem appropriate. But I think what they're saying is if it wasn't, they're not so sure that we need more science on it. But we're not sure in the studies, in the preliminary look at it, that it's really going to be detrimental to let a child drop to the high 80s. And we're not thinking that they're not sure, they don't think it's going to be harmful to that child. We need more science. But we are stopping continuous pulse oximetry on our patients. Chest physiotherapy, action statement 7. Evidence is B, recommendations moderate. Lobar atelectasis is not characteristic, but chest x-ray may show subsegmental atelectasis. Cochrane review showed no benefit in 9 studies for chest physiotherapy. There was a double-blind clinical trial by Sanchez in 2012 that showed a small reduction in length of oxygen with passive respiratory technique, but no other benefit. We do know suctioning of the nares is helpful, provides temporary relief, and there are studies that say deep suctioning is not recommended. It could actually cause more hyperresponsiveness in these children. So, moderate recommendation for no chest physiotherapy. Antibacterials. So, the key action statement 8. Clinicians should not administer antibacterial medications unless there is a concomitant bacterial infection or a strong suspicion of one. The evidence is B. The recommendation is strong. There's lots of studies. And so Sperling in the Cochrane Review in 2011 said the risk of bacteremia is less than 1%. Ralston did a systematic review in infants 30 to 90 days old, and the risk of UTI was 1%. Purcell and Fergie in 2007 found a lack of usefulness of the WC to predict systemic infection. 25% of patients have atelectasis versus infiltrate on chest x-ray, but pneumonia is unlikely without consolidation. Now, otitis is probably the one kicker here, because 2 studies found otitis in approximately 50% of patients early in disease. There is a study that says 73% of children with RSV had RSV in their tympanic fluid. What the guidelines say is that you should treat, just as the previous speaker addressed, you should treat otitis based on the AP guidelines. So if you've got a bulging of the TM in a child who's febrile, you're going to give them a diagnosis of acute otitis media and you're going to treat it. And that's what the guidelines are telling us. So while antibacterial, when there's not an otitis or a pneumonia or a UTI, is not recommended, if a child really has a comorbid bacterial infection, they get antibiotics. And we're not going to go over the AP guidelines for otitis. Action Statement 9. So when we look at nutrition and hydration, remember I said we'd run into quality X? This is it. But we do have a strong recommendation because this is one of those kind of no-brainers. If a child's not taking in fluids, we need to get them fluids. We need to hydrate them. So clinicians should administer NG or IV fluids for infants with a diagnosis of bronchiolitis who cannot maintain hydration orally. And you know, this guideline talks about NG, whereas the previous did not. And when you read it, it talks about there was more success with these babies in putting NGs versus IV. It caused less upset, they felt, to the patient and family, and it was more successful more quickly. So we need more studies on this, and when you see the studies, the recommendations at the end, it's going to be something that we should study a little more, but it's just kind of a no-brainer. Whatever the best way to get fluids into this child, that's what we want to do if they're not drinking. Sometimes they're compromised by their tachypnea and by their distress, and they can't feed. If they can feed and it's not compromising their respiratory status, they should be feeding. But when they can't, then we need to supplement. As far as prevention, we're not going to get into it in very much depth, but these guidelines, the key action statement 10, talks about Synagis. And it really says not to administer to otherwise healthy infants with a gestation age 29 weeks, 0 days or greater. That's strong. It's evidence B. 10B says administer during the first year of life to infants with hemodynamically significant heart disease or chronic lung disease of prematurity. And that's moderate. And evidence C, 5 doses during the RSV season, and that's moderate. I thought it was interesting they addressed hand hygiene. It seems like a no-brainer. It's a strong recommendation. It's evidence B, that we're going to disinfect hands before and after direct contact with patients, after contact with inanimate objects in the direct vicinity of the patient, and after removing our gloves. So, makes sense. And 11B says, use alcohol-based rubs for hand decontamination. When alcohol-based rubs are not available, individuals should wash their hands with soap and water. So that's the one I ended up reading more about because I thought, seriously? You know, I thought it would say use alcohol or wash your hands. But when you read it, the studies say we do a better job with alcohol than we do with washing our hands. So that is why their recommendation is for alcohol first and washing your hands with soap and water only if you don't have alcohol available. It's a strong recommendation and it's evidence B. Tobacco smoke. This was interesting too, because they really belabor it in the guidelines. And I really do think if you've not read them, it's worth reading them through from front to back once. But 12A says clinicians should inquire about the exposure of the infant or child to tobacco smoke when assessing infants and children for bronchiolitis. It's moderate, but the evidence quality is only C. But when you read 12B, it says clinicians should counsel caregivers about exposing the infant or child to environmental tobacco smoke and smoking cessation when assessing a child for bronchiolitis. And that's strong, and it's evidence B. And when you read it, it says tobacco smoke increases the risk and severity of bronchiolitis. It says providers only identify 50% of the patients exposed to smoke. So in other words, we can ask them. They may not tell us So what they're telling us to go ahead and tell them, to talk to them, talk to your families about how detrimental it is. You ask them first, they may or may not tell you, and so we're going to give everybody the benefit of this information and letting them know how detrimental it is. And then the studies show, and I found this interesting, measurable effect of counseling in the healthcare setting. So I hear people all the time tell me, oh, I'm not even going to go there because it's not going to do any good. But really what the study says is, yes, it does. It's worth your time and it's worth your effort because it really does. Key action statement 13 is breastfeeding. Encourage exclusive breastfeeding for at least 6 months to decrease the morbidity of respiratory infections. That's B and moderate recommendations. And I don't know, after just coming from the American Academy of Allergy, Asthma, and Immunology a couple weeks ago, where they're talking about early introduction of foods and food allergy, it's a little conflicting in my mind right now. But I can see where they're coming from here because they found a 72% reduction in the risk of hospitalization secondary to respiratory disease if breastfed for 4 or more months compared with formula-fed. And that clinical evidence supports decreased incidence and severity of bronchiolitis in breastfed infants. So strictly looking at RSV and strictly looking at breastfeeding, it makes sense to strictly promote breastfeeding as a way to make bronchiolitis be less severe. And finally, 14. It's family education. And you know, I don't think we can underestimate how important family education is in the way we manage these children. Because if we think about us as providers and the family as being equal partners in the care of these children, all the guidelines in the world get us nowhere if we can't educate the family to understand that antibiotics aren't needed and that we don't have to keep their child hooked to the pulse oximeter while they're in the hospital, and that albuterol, even though their friend's baby got it, it might have made their friend's baby so jittery and tachycardic that it really made the child look worse than if they hadn't gotten it. So if we don't do a good job of educating our families, we're battling uphill to implement any of these guidelines. We should be pushing for shared decision making. We should be, if we educate, we might prevent that extra emergency room visit. You know how many, you know that you tell each and every one of them this is going to run a course. They're not going to be better by this week, or even, you know, they'll get gradually better, but even next week they're going to be coughing, and maybe the week after that. So that they're not turning right around and running back because, oh my gosh, they've been coughing now for 10 days. Well, if we were really clear with it, and sometimes those are the things I actually write down. Because with a mom with a sick baby and you're telling them it's going to be, you know, what do you say? Oh, they're going to be coughing for a little while? Yeah, they get home and what's a little while? Oh my goodness, it's been a week now. And if we say it could be 2 to 3 weeks or maybe even a little longer, they're not nearly as jammed up. And you say, but we're going to be watching how much they drink and making sure, you know, now that their fever's coming down, that, you know, they stay without that fever. And, you know, if you do a good job of letting them know what to expect, you'll do a much better job of keeping them from returning. And then they'll know when to call, too. You know, if you don't tell them when to call, they don't know when to call. Also, good hand washing, prevention of the spread of infection, and then not having them begging for antibiotics or going to someone else to get antibiotics. We see all the time, you know, they've been to one emergency room, one urgent care, and now our emergency room, they're really looking for is antibiotics. They want, you know, they want something that those places aren't giving. And if we all stick together and give good advice and good information, we've got a much better road ahead. Then how do you implement the guidelines? So you heard something today maybe that you're really not doing, and you go back and you talk to your colleagues, and they say, you've got to be crazy. You know, if we don't give albuterol, you know, these parents are just going to go somewhere else for albuterol. So it takes a lot of work. It takes a lot of agreement of key stakeholders. It takes a lot of putting into place the guidelines that you decide to stick with, and it takes a lot of consistency. If you have electronic health record, we really promote consistency by our electronic health record. We put in a standard ordered set that kind of guides the practice that we're trying to put into place. Our order set, our documentation, we track outcomes. And it's hard to track outcomes, but electronic health record makes it a lot easier. And then we try to keep up with the new evidence. This you probably can't see, but you're going to run into some battles. This is up to date. I think it was from January 28th of 2015. And I wanted to see if up to date was up to date with the new guidelines. And so when I looked, I found that they referenced the Ralston article, and I'm thinking yes, and I was about to leave it at that. When I went down to the bottom and I read, I can read it over here. Oh, I can't. It says, while we no longer routinely suggest inhaled bronchodilators for infants and children with bronchiolitis, a one-time trial of inhaled bronchodilators may be warranted for infants and children with bronchiolitis and severe disease, nasal flaring, retractions, grunting, respiratory rate greater than 70 per minute, dyspnea or cyanosis or respiratory failure. So I think what they're trying to say is it's still in the kitchen sink. What I hope they're not saying is go ahead and give a one-time trial, because that's what the last guideline said. And that's not what this guideline said. This guideline said don't do that one-time trial unless you're in the kitchen sink protocol. So I'm hoping that's what it said, but I was a little disappointed. It was a little misleading. This I put in here just for your own humor, because I was talking to some of the the community pediatricians at the hospital about doing this talk, and one of them said, have you seen the likelihood ratio? I said, the likelihood ratio, is it a scoring system? He says, no, it's a blog. I said, no, I haven't seen it. He says, oh, Ann, you should just do the likelihood ratio for your talk at the conference. And when I went, he said, look it up. So I looked it up, and I want you to look it up, because what it is it's like a humorous spin on the guidelines. So it takes each action statement one at a time. 1A, 1B, 1C, 2, it goes right through them. And he actually sort of mocks it, but he sort of points out how hard it is. So the one that I can read from here is, under treatment, it's action statement 2. It says, once you have diagnosed bronchiolitis, run and get your office's nebulizer. Take it to the parking lot and dash it to the concrete until it's irreparably broken. What were you thinking? Considering giving that kid albuterol? Now you won't be tempted. He does it to each and every one of the action statements, and it's really pretty funny. There's other funny ones in there too. But he said he went to someplace like at Harvard or someplace, and they did a talk on the guidelines, and actually all they did was they read the blog straight down the line. So, and then I just left my brother-in-law, who's a pediatrician in Cleveland, yesterday, and he said to me, how's that talk going to go tomorrow? How long did you say you have? And I said, I have an hour and 15 minutes. And he said, one blank slide, an hour and 15 minutes? He said, what are you going to tell him to do? So when you get to the end of the guidelines, I think we all know, as we go down the line, it's telling us a lot of don't do this and don't do that and don't do this, and we don't have a lot of do this, do that from these guidelines. Future research, oh my goodness, look at all this. I could think of more you could add to it. But we need better algorithms to predict course. We need the impact of that clinical score on the outcomes. We need to evaluate different ethnic groups and varying responses to treatments. We need to know, does epinephrine alone reduce admission in outpatient settings? Is there additional studies on epinephrine in combination with steroids? Does hypertonic saline studies outpatient in hospitals with shorter length of stay? Are there more studies on NG hydration? Are there more studies on tonicity of intravenous fluids? Is the incidence of true acute otitis media and bronchiolitis using the 2013 guideline definition? Do we really know? Are there strategies for monitoring oxygen saturation? Should we use home oxygen? I found one study on it that suggested that we send kids home from the private office with home oxygen for a few days. That would really be a sad state of affairs, I think. If we do that, how will you ever rein that in? And when will you decide to do that? And who decides who goes to the hospital and who goes home? Appropriate cutoff for use of oxygen in high altitude. Oxygen delivery by high-flow nasal cannula. We don't have good studies on it. RSV vaccine and antiviral agents. Use of Synagis in special populations. Emphasis on parent satisfaction or parent-centered outcomes in research. Not just looking at length of stay or the cost of admission, but look at how parents feel about their children and they're being cared for. Based on the guideline, I want you to see if we can come up with these answers. A 4-month-old, previously well, you have to think about it's late in the day, so pay attention. Okay. A 4-month-old, previously well, presents with 3 days of runny nose, congestion, harsh cough, less than normal PO. On exam, thick nasal drainage, very mild wheezing, respiratory rate of 40, O2 sat of 96 on room air, no fever, appears hydrated. What do you do? Yeah, saline spray and nasal suction. We don't need albuterol on this kid. We don't have to change their feeding and to Pedialyte, and we know we don't need a chest x-ray. A 3-month-old, previously well, presents to the EU with 2 days of coughing, fever to 38.6, pulling at ears, taking usual feedings. Siblings got RSV. On exam, both TMs pink, not bulging. Mild wheeze on auscultation. Slight abdominal breathing. Respiratory rate 38, O2 sats 96 on room air, and the temperature is 38.4 when you see them. What do you do? Tylenol. Do Tylenol. They have a fever. They're feeling crummy. Lots of babies pull in their ears when they're just feeling crummy and they don't need antibiotics for their ears. And then we could always do albuterol at 3% saline. I don't think it's the best option here. Based on the guideline, an 8-month-old, previously well, with a history of 4 days of coughing, fever, poor PO, comes to the EU. On exam, moderate wheeze throughout, mild intercostal retractions, respiratory rate of 50, O2 sat of 93%, temp is 37.9. Do we do viral swab, chest x-ray, albuterol, or oral fluid challenge? Seemed like the biggest problem was probably that poor PO, so let's see what they do. And you know, sometimes I think we suck out their nose, give them some Tylenol, and challenge their fluid and see if we get them to feel a little better, will they drink a little bit before they go home. Last one. 14-month-old with a history of wheezing that includes 2 previous EU visits. Presents to the EU with wheezing, runny nose, cough, increased work of breathing. Siblings are also sick. Mother tried albuterol 1 time at home. On exam, respiratory rate's 52. The O2 sat is 92. Wheezing throughout. Intercostal retractions. No fever. Good PO. Chest x-ray, albuterol, viral swab, or IV fluids. This kid's the outlier. This kid's had previous wheezing. He's a recurrent wheezer. He's off the bronchiolitis pathway. He's now on more of an asthma pathway. He may be triggered by the virus, but he's proven to have other wheezing episodes. I could have made it stronger by saying he's responded to albuterol in the past. But this kid is a kid who, yes, the guidelines aren't talking to this kid. Guidelines aren't talking to the recurrent wheezer. So in conclusion, the bronchiolitis treatment per the 2014 guidelines, a summary. Diagnose and assess severity based on symptoms. Lab and radiology are not recommended. No recommendation for albuterol, epinephrine, or systemic steroids. Hope my brother-in-law's not listening right now. No recommendation for hypertonic saline in the EU. May choose not to administer supplemental oxygen. This is a for sure if the saturation is greater than or equal to 90%. And continuous pulse oximetry is not needed. No recommendation for chest physiotherapy. Antibiotics only if concomitant bacterial infection, and administer IV or NG fluids to maintain hydration. So do guidelines lean to cookbook health care? I have people say that all the time. You don't need to know anything anymore. You just have to look at the guidelines and do what they say. They say, is that what you're trying to tell me to do? No, that's not what I'm trying to say. Really, I think there's evidence, which may be a little bit of our cookbook, plus art equals patient-centered, evidence-based, outcome-focused, cost-efficient healthcare. We've got time for questions. We've got time for questions. Anybody have a question? Yes. He's still worried about oxygen, aren't you? Oh, not this time. Okay, good. Okay. Steroids, no steroids is the question. Excuse me, say it real loud. Yes? Stridor. If there's Stridor would make you think racemic epi might be a good option. No, Stridor would definitely make you think racemic epi might be a good option. It would be no different than if you had a kid with croup at that point, probably. It would be the most reasonable of the treatment options to try. Absolutely. Yes, no. So thank you for clarifying that. Stridor, you're thinking more croup. Once you're thinking croup, then you're thinking not only racemic, but then you would be thinking dex if you think you're looking at croup. Yes, there's evidence for that. Anybody else? Yes. Yes. I think a rapid flu is not a bad idea if you're suspecting influenza. If you're seeing high fever early in the disease and you think you might have influenza and you want to try to treat a child with Tamiflu, science on Tamiflu is not great either, but if you're considering Tamiflu and you really want to know if you've got influenza, a rapid flu would not be a bad way to go. I'm a little conflicted on Tamiflu. Yes? Nebulized saline, just plain saline nebulized. There's no science on it. So if you're going to do saline at all, the only science we've got right now is the hypertonic, which is the 3%. Anybody else? All right, I think we did it. Thank you.